Welcome to Let's Talk Value podcast series in the fall 2023. It's already our fifth season. My name is Verena Wolter. I'm the CEO and founder of a boutique healthcare consulting firm called 5P Healthcare Solutions. And I'm also the author of the book, It Takes 5 to Tango. And we'll talk a little bit about that value chain. But today, I'm really pleased to welcome Jennifer Clawson. Hi, Jennifer.
Hi, Verena. Thanks so much for the invitation to join you today.
So Jennifer is a really largely, widely accomplished leader in healthcare. And that's what we do on this podium. We really invite in people with a lot of depth and breadth of expertise on how to solve what we call the quandary or the dilemma of all the silos. And, we talk about patient centricity, we talk about value generation, and then we turn around into our day jobs. And across pharma and payers and policy and patient and doctors, we continue to do the same of the old. So we want to learn a little bit more. So Jennifer is not only the lead of the value-based healthcare practice as Boston Consulting Group, but something that we'll talk about more in depth today is she's the co-author also of a recent book. And we see it for those who are watching in the background here. Here she goes, The Patient Priority. So Jennifer, as always in this series, I used to kick it off in a very 10,000 feet view level question. What does value mean actually to you? If you only have an elevator pitch or you need to explain to your mom, what comes to your mind?
It's always a great question to start with, because in fact, I think there are too many definitions of outcomes out there and value as well. We define value in our book as essentially improving the outcomes for patients, the things that most matter to patients, as well as using the scarce resources we have with our healthcare systems to improve the care that's provided. So it's a combination of an individual focus on improving what matters most to patients and using our scarce resources, both the human resources in terms of healthcare practitioners and our financial resources to get better care every day.
Thanks, Jennifer. And obviously that is, as always, it's easy said, and it's the right theory. But the good thing, and we just spoke about, you come off, or many listeners come off a recent big conference on the topic. It's really good to see over the past 2 decades now real stuff is happening. And we really are eager to hear from you also some examples. But as we kick us off, and we'll talk about the two sides of that coin, the outcomes that matter, and then how do we finance it, or how do we find the resources, or how do we make them more efficient? So we'll talk about the latter one in a little bit, but we'll start with the outcomes, and we really mean patient health outcomes, right? So that then comes to mind very quickly a buzzword or hashtag patient centricity. And obviously your title is right away like patient priority. So tell us a little bit, then breaking it down on practicalities, how can that look like actually in a real care delivery, like involving the patient? I mean, that sounds great and nobody can have anything against it, but what should we be thinking about when we say that?
It's true. I think at the end of the day, a lot of people agree in concept. There's hardly anybody who won't agree with value and patient centricity, but it's really hard to make it reality in practice. And so, when we talk about patient centricity, it really means, first of all, measuring what matters most to patients, as I just mentioned, but then using that data in conversations, patients with their healthcare providers, and also among the multidisciplinary teams of practitioners. So that means getting together the nurses, together with the surgeons, together with the internists, et cetera. It means using the data that's collected to help drive the improvements. We thought early on about, well, what are the real barriers? Why are we not seeing more of this, right? And so at first, and part of the reason why 11 years ago now, believe it or not, we co-founded ICHOM, which stands for the International Consortium of Health Outcomes Measurement, a not-for-profit that actually defines sets of patient-centered outcomes. We thought at first it was really about, well, we're not sure what to measure. We don't have standardized outcomes. We don't have clear guidelines on what that should be. So over 11 years, the ICHOM teams have, with over 1,000 experts across 60 plus countries now, have defined these outcome sets that cover the majority of conditions that we all face. 60% of what we spend on healthcare is covered by these outcomes. So it's no longer about what to measure. And I think we talked about earlier, and you highlighted the why. The why is clear, and everybody, I think, agrees on that. So then again, the question comes back to, why aren't we seeing more of it? And I think then we realize that, well, it's about getting this into the regular clinical pathway care process. And how can we get both the patients as well as the healthcare practitioners more engaged in the measurement side? So we went through both with BCG, but also specifically with ICHOM, a process to really develop the technical standards. How can we take these outcome sets, map them to SNOMED, ICD codes, and also make them ready to integrate into electronic medical records by using FHIR standards, which is quickly becoming the international standard for health data, et cetera. So now I'm happy to say that we have what to measure. We have ICHOM sets, we have the digital solutions, that we've overcome the technical problems. And now the biggest hurdle still remains changing the human behavior. So that, I think, still will be an issue, but we've gotten some of those technical solutions there.
Exactly. So, and you know that what my kind of theme and compass is what you say, the behavior, or when I have a bad day, I say the silos. And when I have a good day, I say the different actors working together. So, you know, we work with a simplification called the 5 Ps of patient, provider, pharma, payer, policy. But of course, there are many more Ps. There are pharmacists, there are physiotherapists, and whatnot. It doesn't matter. You can slice and dice the cake as you want. There are too many intersections for a patient in their journey. So I so agree with you and your group on, at the end, it's the individuals that make it happen. I think you and ICHOM have done a great work. So we have the frameworks, we have the technique, we have the tech, we have the IT and the data and software. We have frameworks, we know how to code. So how do we move the people?
Yeah. So,
You know,
it's a good question. And if I'm reflecting back just over the past 2-3 weeks, I guess, of people that I've been able to interact with, hospitals I've visited, patients I've talked with, et cetera, I'm encouraged because I do see more momentum. And it's a combination of momentum from the top. In other words, these big initiatives, leveraging the big frameworks and things, as well as the individuals on the ground who learn about this, get excited about this, and really think that they can drive the change in their own departments. So let me give you 2 practical examples. At the top-down level, I think there's, within Europe, a great initiative called H2O. H2O, obviously the chemical symbols for water, meant as an analogy to using water as a utility. It stands in this case for Health Outcomes Observatory. Health Outcomes Observatory, or H2O, is a public-private partnership aimed at basically collecting and integrating at scale patient-reported outcome measures. And so it's really aligned with the value-based healthcare principles, aligned with outcome measurement, and bringing together both the public side in terms of public hospitals with the private side. So funding through the European Union, the European Commission, IHI, the Innovative Health Initiative, FPIA, the Pharmaceutical Industry Association, et cetera. So it's a really, truly public-private partnership. And they're focusing initially on 4 countries in Europe and 3 different population groups. And so that, I think, is really have legs, and it's being implemented, and it's going to have real value. And then, you take the bottom up side. I was speaking with a nurse in the cardiology department of a leading hospital in Barcelona recently, and she was telling me with great passion about the change that she was helping to drive in her department with the patients, as well as with the doctors and the other nurses, to really include outcome measurement as part of the remote patient monitoring program for any patients with implantable cardiac devices in her department. So it wasn't a new activity per se. They've been doing remote patient monitoring for a while, but they really started to collect the data and use it more proactively to improve the patient pathways. And she was really excited about some of the results they're seeing early on.
And I think this is great. A couple of things come to mind. It doesn't always take everybody at day one to collaborate. And I like that, even in the smallest unit, microenvironment, maybe a nurse, maybe a doctor, maybe a student. We are working even with medical students, start somewhere with one little piece. And I think I can't remember who said it, but it's almost like a big puzzle. And then, so it's really about every single piece in the puzzle, and everybody can implement. And it's so hard to see the entire big picture all the time of what we want to do. But so the encouragement to start small and look around in your environment, what's going on, and get engaged. The other piece is it's not a big theme for our talk today, but it's a little bit, the digital transformation. And I'm always, when some of the critics and cynics say, well, value-based healthcare has existed and has been described 20 years ago. Here we are, not implemented. It's to prove it's not working. But some of it is also because with pen and paper, it's just very hard to do it to scale. So do you have any other examples on where really, you mentioned EHRs, you mentioned remote patient monitoring and variables. Patients now can be actively involved with their apps, with their providers. Any other ideas of where this can be used to the benefit of the transformation to measure outcomes?
Yeah, I think at the end of the day, you're so right. We have to walk before we can run. And sometimes I think that it's a bit scary to think about, well, outcomes, ICHOM has 40 plus sets and there are a lot of them and we have to do them all and we can't. But this idea of starting small really is critically important. Again, maybe a small sort of bottom-up example that comes to mind. A couple of years ago, we were working with some patients who have type 1 diabetes. In other words, patients who have had basically since being born, a condition that they're actively dealing with throughout their life. And we were asking, you measure a lot of things in your country with your doctors. What is it that, keeps you up awake at night? What is it that worries you? And he was telling us, well, actually, it's my anxiety. It's not knowing when I'm going to have an acute episode. It's not knowing whether I'm going to be able to complete my next personal challenge. It's not knowing enough about my condition in a way that I can actively manage it. And we asked him, he said, well, are your doctors talking to you about that? Are your doctors actually measuring your stress and anxiety levels? Because as we all know, stress and anxiety has sort of been a hidden issue and it's becoming more prominent now that we're able to talk about it, especially, since COVID. But he said, no, not really. And it was a result of that although they measured a bunch of things already, it was a small addition, but had a huge impact for him and his other fellow patients of type 1 diabetes to start to measure in a systematic way my anxiety level. Because therefore, once we have transparency on it and once we measure something, then we can actively do something about it. And so I think that it was a great example of sort of a bottom-up way of understanding by asking the question, what matters to you? What are we not doing? What are we not talking about? And start to actually put some light on that in terms of adding a small measure, start small, but had a significant impact. It also has a significant impact in that particular case on healthcare costs, because it helps by measuring, can help avoid some more acute episodes that would require intensive care that would be preventable. And so I think there's an increased emphasis and realization that by measuring a couple of key things, I can actually do some prevention efforts as well.
This warms my heart. It's a wonderful example, and it's so, quote unquote, simple. So you don't need a huge technology in that example. It's as simple. And maybe for all my doctor peers here in the group, please continue to ask that question. What matters to you? What is important to you? I know many doctors are still under a fee-for-service and RVU system. They are pressured by their administrators to see even more patient per 5-minute time unit. But that question takes, I don't know, I haven't measured it, 10 seconds maybe. So that is very important. And also in my book, we also talk about type 1 diabetes, and I actually do actively work with a patient in my team with type 1 diabetes. So I think this is really, really important. Also the mental side of things. And yes, you said COVID, I think generally maybe there's more sensitivity to mental health issues nowadays. But I think importantly, in the old system, we thought, oh, somebody has diabetes, easy, you give insulin, end of the story. Now we understand, and that's exactly what it is, outcomes that matter to patients. It's a good segue maybe to our last leg in the conversation. We said we would talk a little bit about cost, and you started talking about it. And I like in this example also the power that the PROMS measurement can have directly on the cost denominator. Talk to us a little bit. You started mentioning the prevention side. So we can, how can we utilize that more and then by, watching out for possible complications and get ahead of the curve.
Sure. I love to start this conversation about cost by thinking about putting it into context, right? So both the OECD and the WHO have done some studies over the years that estimate, depending on your healthcare system, somewhere between 20 and even up to 40% of what we spend in healthcare is wasted. In other words, it's not helping us improve the outcomes for the patient. And I think having that as a backdrop to the cost conversation is always helpful, because we think, well, if we cut back on costs, we're going to be rationing care, we're going to be providing more inequitable care, we're going to be withholding access. And in fact, I think that's really not the case. I think that one of the keys to unlock and discover where that waste is happening is by doing more systematic outcome measurement. If we systematically measure the outcomes for health and healthcare for all the patients we give care to, that I think will more easily, nothing's easy in healthcare, but more easily help us identify what is contributing to the waste. What is it about the care that I'm providing that can be either streamlined or even removed from a particular care pathway? And so, for example, we did some work with some European hospital organizations a couple of years ago, and we looked at outcomes in 7 independent hospitals within the same country. So, the doctors have been trained in the same way, they've been to the same medical schools, they've come up through the system similarly. We were surprised, and they were especially surprised to find 7x difference in an outcome measure for breast cancer patients. And so then, using that data, which brought new insights to them, we started to ask, okay, well, describe to us the way that you do your practice. Describe to us the way that you do an intervention to remove cancerous tissue from a woman with breast cancer. And getting to that level of conversation about what is the process through anesthesia, what is the process through the surgery, what is the process before, a recovery, et cetera, we were able to understand some of the minute that, you wouldn't necessarily capture without measuring the outcomes, the minute differences that contributed significantly to that 7x, and also importantly contributed to the cost. So, taking back to your original question, the cost, we can get to that in a much more effective and long-lasting way by looking at the outcomes and then reverse engineering what do we not need to do, or what can we do, which may cost a little bit more in the short term, but save us significantly in the long term, because we don't have to do a reoperation, we can do some prevention, we can avoid things that are costly that don't actually improve the outcomes, et cetera. So I think attacking the cost problem by measuring outcomes is a big unlock.
Wonderful. And wonderful to throw the waste part into it, because that's exactly what it is, and what we can help to identify where this happens and then replace it by more meaningful care. To finish us off, and you have already mentioned a partnership example with H2O and others, because I think some of the things that have really held us back to be more effective in the value-based healthcare implementation is we were still too much thinking in our silo, and that's the issue. I'm always saying, for the business people here, we are not in a B2C business, we're in a B2B2B2B2B2C business. So unless you touch all of those pieces in the chain, you can't really move the needle, nor on outcomes, nor on cost. So any other partnership models or anything that you could encourage people to think about, as they walk away from this episode?
Sure. Yeah, one of my favorite ones, and it's a great question, thanks for asking, is the Linnaean Initiative. So let me give you a little bit of a backdrop and paint the picture for you. The Linnaean Initiative is something that started back in 2017, again, at an ICHOM conference, actually, an ICHOM conference that at that point was held in Washington, D.C. Linnaean is the name of a street. It refers originally to the Swedish scientist, but it's the name of a street in Washington, D.C. It happens to be the street where the Dutch embassy is located in Washington. And what happened at that particular ICHOM conference 6 years ago was there was a large contingent of people from the Netherlands who were present. And they decided to, in addition to attend the conference, have a side meeting. And from that, they launched what they called the Linnaean Initiative, named after the street where they were having that side meeting. And effectively, it's an open membership partnership. In other words, anybody who is a practitioner, a provider, a payer, a life science industry, a patient, etc., are open and welcome to join. And what they have done over the years is develop a series of checklists and a series of challenge questions on implementing value-based healthcare, implementing outcome measurement, and carrying that through to all the B, to B, to B, to B, to B, and to the C, as your question referenced. And they have two mottos, which I absolutely love. One of them is that acting is the new thinking. In other words, why can we not just move on? We've done enough thinking. Let's not let perfect be the enemy of good, as they say, but let's just move on with it. And their second motto is sharing is the new having. In other words, I think in my mind, I read that as related to healthcare data, specifically outcomes data being one part of that, but sharing is the new having. We all hold different pieces of the puzzle, as you said, and we can only, by putting them together, really get the true insights we need and are looking for ourselves as patients and caregivers, but also as healthcare practitioners.
Well, already almost up with time. And this was a wonderful conclusion of what is a super complex topic. Do you have any last comments you want to leave the audience with? Because obviously people can go back and read at their leisure your book and other publications you've led, but anything you really want to make sure they pay attention to?
Thanks. I guess what I would say at the end of the day, two things. We are all patients. I was at a conference recently and somebody said, can I see a show of hands of patients? And a couple people raised their hand and said, you're all wrong. We're all patients. And so I think as patients and caregivers, the challenge to ourselves, are our doctors asking about what matters to us? And if not, can we challenge them to include that in the conversation? And for those who have the privilege and the ability to work directly with patients as caregivers or as healthcare practitioners, what is your organization doing to measure what matters most to them? And can you do something a little bit differently tomorrow to help improve that? So I think starting small, outcome measurement is critical, and we can hopefully all do a little bit something more tomorrow and drop something that may not be adding as much value.
Thank you very much, Jennifer Clawson.
Thank you, Verena, for the opportunity.